I'm Al Farrow. I'm Senior Director of Clinical Affairs at the Foundation. I hope many of you had the opportunity to hear the very brief presentation I gave yesterday. It was sort of a 10-minute whirlwind, sort of the 10 countries in 7 days European tour. We hope that we'll be able to give you a little bit more detailed conversation today and certainly answer all your questions. I'm joined today by Erin Tallarico, who's the director of our lung transplant initiative. Erin, as I mentioned yesterday, was someone we stole from Hopkins. She was a CF nurse coordinator, but in a previous life was also a transplant coordinator. Now, not lung, but pancreas and kidney. And then in a previous life to that, you've had a few, worked for an organ procurement organization. So she kind of knows every angle of the transplant business as well as CF. So we're very, very fortunate to have stolen her from Hopkins, and maybe one day they'll talk to me again. So what we hope to do today is, as I said, go into a little bit more depth, give you a little bit of background of how did we get here? Why did we decide to start this crazy initiative from scratch anyway? Why the need? And what are the focus areas? And where are we now with the initiative a good year and a half into it? So it actually started about 5-6 years ago during the Foundation's regularly, there's an interval where there's a comprehensive strategic initiative that's drawn up. And it was clear that there was an opportunity in the area of lung transplantation, and we heard loud and clear from the community that this was important to people with CF and their families. In point of fact, we heard lots of feedback about how difficult the process was and how frustrating it was. And in fact, how people also even didn't feel like they were part of the CF community anymore once they embarked on the transplant journey. So the Foundation took all this very, very seriously and took a long, hard look at what could be done. And so in 2016, they talked to Dr. Joe Paluski, who, as I mentioned yesterday, adult CF and transplant pulmonologist at the University of Pittsburgh. And he was kind enough to volunteer to lead a summit that was held in the spring of 2016, I think it was March 2016, where lung transplant experts throughout the country were invited to come to the Foundation and help the Foundation think about what plan to take and move forward. How could we make the transplant process better for people with cystic fibrosis? And the end result of that was I eventually came and joined the Foundation as well. And Joe and I started to come up with plans and move forward to see how we could provide greater support for lung transplant care and research from the Foundation. And not only did we see an opportunity as in regards to helping light the path for people and providing more information, more education, helping guide them in terms of finding resources, but also because the outcomes after lung transplant are not what we want them to be. And what you're seeing right now is what's called the Kaplan-Meier survival curve. And what I just want you to really notice is that people with CF are the purple line, and all other diagnoses that can lead to end-stage lung disease and lung transplantation are the other lines. And in a curve like this, the higher you are, the better, because it means longer survival. And what you can see is CF is on top of everyone else. And in point of fact, this is data from the International Society of Heart and Lung Transplant. So they have a registry of post-transplant outcomes. And when you look at 50% survival, so median survival, that means that half of all people at that time point are still alive. So this is after a lung transplant. And in CF, you can see that actually people with CF do better than any other diagnosis. It's 9.2 years for a median survival. Now remember, that doesn't mean that if you get a lung transplant, you're going to live 9.2 years. Because the survival after lung transplant is very variable. There are people who can live just a couple of days, and there are people who can live 20, 25 years after a lung transplant. This just says that 50% of people who've had a lung transplant are alive 9 years after having had that lung transplant. And that's compared to about 5 years for people who've had other diagnoses. So we're doing much better than other diagnoses, yet that's not good enough, right? We're not satisfied with a median survival of 9.2 years. So we saw an opportunity where we could take some of our secret sauce and perhaps improve lung transplant outcomes. So Joe and I and others at the foundation sort of sat down and thought about a mission statement, and we came up with to improve the care and long-term outcomes of individuals with CF and advanced lung disease by optimizing decision-making and access to lung transplantation and improving outcomes after lung transplantation. And this is what we're focused on doing organizationally. So as I pointed out yesterday, very importantly, this is more than just a handful of people doing this. This is an organization-wide effort. And I'm not going to talk through this slide again. You guys were already forced to listen to me talk about it for 10 minutes yesterday. But really the focus remains on people with CF who are trying to determine if lung transplantation is the right choice for them. And then if they do, help them all along that process from trying to make that decision to post-transplant. And simultaneously, as we've been building all of this, we brought together a group of expert lung transplant sites. And we sent out what's called a request for applications. And we sent it out throughout the country to all transplant programs. We did make it clear that our expectation for those who were going to join this consortium was that they were going to be transparent and collaborative. So we received 16 applications. There are some 55 programs in the country, so it's not like everyone wanted to apply, at least at that time. We funded 10 of those programs, and those are the ones that you can see on your right-hand side. And as you can see, they're all really big academic centers, some of them with big CF programs, some with smaller CF programs, but all of them do a lot of CF lung transplant, and all of them are top-notch transplant programs. And importantly, they were willing and ready to be collaborative. And our objectives of bringing these folks together was to address multiple issues. First, share your protocols, and let's see if we can understand what is the secret sauce at one program versus another. Are there things we can learn from each other? Importantly, if we reduce the variability in care, can we then have future studies to accelerate our learning and progress? I mean, that's been part of the magic in cystic fibrosis, has been our ability to reduce variability in care. It's not perfect. We have our guidelines out there. We never get 100% implementation of guidelines, but we've reduced a lot of variability in the care of people in CF throughout the country. Whether you live in Miami, New York, Seattle, St. Louis, or so on, you tend to get the same flavor of care. And we're hoping to do the same within the consortium, within these sites. We're also benchmarking these sites. Again, something we've done very successfully in cystic fibrosis, which is we go and try and learn what it is that they're doing well that we can disseminate then to other programs, and maybe they can take back within the context of their own local realities and adopt some of those secret success variables. We're working at building this shared database, and we're doing that by building onto the CF Foundation Patient Registry, which already has a lot of rich data pre-transplant, and we want to add post-transplant data to that. And then build a shared biorepository where people with who've had a transplant undergo lots of procedures. They have lots of blood tests, lots of bronchoscopies, lots of biopsies done. If we can store some of that tissue, maybe in the future we can use that when we start to test therapeutics in transplant. Again, part of what we've done in the CF. So basically we've stolen the CF playbook and we're moving it to transplant. And for good reason, it's been very successful. And we already mentioned the allow for multi-center studies. And now I'll pass it on to Erin.
Thanks, Al. It's a pleasure to be here with all of you. And just a quick reminder, if you have questions, You can submit them online at cff.cnf.io. And now I will take us into some of our working groups that we've put together. The first one is our CF Specific Referral Guidelines. So this group is led by Kathy Ramos at the University of Washington and Jordan Dunitz in Minnesota. And it's comprised of physicians, we have nurses, dietitians, pharmacists. It's a multidisciplinary group. Again, taking the model from CF and moving it forward with our transplant projects. So the goal of this is to provide patients and families and care providers guidance on the transplant process, which we have heard loud and clear is difficult. It's confusing, it's frustrating, it's scary. So we're looking at 3 specific aspects of this with the group, and one of them is the timing for referral and the components of transplant. The other one is modifiable barriers and listing. So we want to make sure that if there are modifiable barriers, such as support, most transplant centers require you have 1, if not 2 support people. We want to know that up front so we can help with that. So looking at those modifiable barriers and how can we make sure that that person is in the best possible position to move forward with transplant. And then the third group is looking at the transition to transplant and the consideration of the patient and the caregiver perspectives. So this is very exciting and unique. We're actually using a focus group that is run by a patient who's post-transplant and a psychologist from Duke. And the group is made up of about 8 to 10 patients and family members. And they have been getting together on the phone every other week for the past few months and talking about their experiences. And they are coming back to the full group and letting us know some things that we should incorporate into these guidelines, which is really exciting. Our next steps are to get together in May, where each group will come with their list of recommendations, and then the whole group will vote on those recommendations. Once we have those recommendations, they'll begin writing over the summer, and the hope is that we will have something out for public comment by the end of the year. We also, part of this, want to develop educational tools and resources and toolkits, so to speak, so that patients, caregivers, transplant teams, CF teams have real life things in front of them and tools to use to help patients through this process. The other part of the referral process we've been looking at is quality improvement, and we have a quality improvement initiative in collaboration with Dartmouth. It's our Lung Transplant Transition LLC. We kicked this off in October, and it's our 10 transplant centers all identified one of their top CF referring centers to partner with. And since October, they've been working individually, the transplant team together and the CF team together, and the aim is at improving the transplant transition process. So we want to improve and decrease the practice variation and all the different processes involved with lung transplant, and move towards a transplant and CF model to a combined model. So they are taking a shared responsibility for this patient after transplant. And this graphic shows you just that. We have our referring program and the transplant program with the patient and the family in the middle. And together, and they're coming together again next week in DC, and at that point they'll start working as what we're calling the transplant transition team. So they'll actually start working together on these processes and how we can improve the referral process, with the hope of then disseminating that out to their other referring centers to learn from. The other exciting thing that they did site visits. So each transplant center, the leaders were able to go and see the CF center and vice versa. The leaders from the CF program went and spent a day or two with the lung transplant program. And I think this was a very unique opportunity for those two teams to actually see what each other were doing. And they came away from that with a whole new respect for the challenges that each other face, so that they can now come together and work on making those better and improving those. The second group we have are guidelines for care of advanced lung disease. So the goal for this group is to increase the knowledge and issues specific to individuals with advanced CF lung disease and to improve their quality of care, regardless of if they choose to go down the transplant journey or not. So we have 3 subgroups within this working group, and the first one's looking at medical management and bridging to lung transplant. So some of the things they look at is, are we optimizing medical management and treatments? Are patients using supplemental oxygen? Are we using non-invasive ventilation like BiPAP to help bridge these patients to get them to transplant? Management of comorbid conditions is another. So CF obviously is a lot more than just lungs, so they're looking at sinus disease, CFRD, so diabetes, and how all of these come into play, as well as kidney disease and GI complications. And then the third group is looking at symptom management and end-of-life planning. And this is where pain management comes in, mental health, anxiety, depression, listening to the voice of the patient. We have a family member on this subcommittee. And how do we support them through this process? And we're also looking at palliative care, which I should mention is its own subgroup that Al also takes the charge on, that are developing their own set of guidelines, but it certainly has its place with advanced lung disease. So they're looking at that. And the timeline for these draft guidelines is about 12 to 18 months, a little bit further out than our referral guidelines. And then the third group, they're looking at developing post-lung transplant recommendations. They're looking at what is unique to CF post-transplant. So once you're transplanted with lungs, you still have CF. You still need to take enzymes. You still need to deal with sinus disease if you did pre-transplant. So we're looking at all of those unique variables for CF post-transplant. We're in the final stages of putting that committee together, and we'll be kicking off this spring with, again, an 18-month timeline. This group is led by Polly Shaw at Hopkins and Ramsey Hashem from Washington University in St. Louis. And then our fourth group is what we call our research group, and Al touched on this earlier already. So one of them is working on the clinical database. So what variables do we need to add to our CF patient registry? What variables specific to the pre-transplant space need to be added? And then what variables post-transplant do we need to add to increase our ability to do some research? And then the other part is the biological samples that Al referred to. So our basic and translational group is looking at what samples do we need to collect, tissue, blood, specimens from bronchoscopy, so that down the road we can have those available for our research purposes.
So I'm happy to say that the research aspects are actually starting to fire on all cylinder. They were sort of the slowest to develop. We did, when we sent out that request for application for the consortium sites, we also did send out a request for applications for research, and there were actually 36 applications submitted for research, and we funded 9 of them. Some focused on chronic rejection, some on other aspects of transplant, including, as I may have mentioned yesterday, we funded some research in that ex vivo lung perfusion, which is really neat. But what we really wanted to do is focus on larger research studies impacting chronic rejection, because chronic rejection is the major barrier to the long-term outcomes that we wish to achieve for people who undergo lung transplant. And so we held a research workshop just 2 weeks ago in Bethesda, and we brought in not only lung transplant experts, but experts in other transplant areas, as well as just basic science transplant immunologists. And it really was energizing to see how these people fed off each other and built on each other, and really were starting to think about ideas for collaboration to move this forward. So we're going to be sending out another request for application based on what we've learned, and we'll be sending it out this summer. Hopefully get some nice research proposals in and fund. We're envisioning, again, funding some bigger research projects to help us understand chronic rejection, characterize it, because even now we're quite limited. Our characterization is mostly based on lung function testing. So we'd love to find blood tests, radiographic imaging, biomarkers from bronchoscopies, other aspects that characterize the development of chronic rejection more granularly, so that perhaps that will help us when we start thinking about therapeutics in a developmental pipeline for lung transplantation to either prevent or treat chronic rejection when it occurs. So it means finding biomarkers, not just relying on, oh, it's here, someone's got chronic rejection because their lung function has dropped 20 points, right? So it's a little late. We want to mitigate the progression of CLAD by understanding it earlier. And we're going to be looking at, based on what we learned, certainly things like the airway microbiome, the way the lung responds to injury and repairs itself. And there were all sorts of neat tools. One microbiologist brought with him this little box. I mean, he pulled it out of his coat pocket. And it only costs about $1,000. And it can take a blood sample and run your entire genetics on it. Now, since he's a microbiologist, when he puts a sample in it, all he cares about is bacterial DNA. So that's only about 3%. So the other 97% he ignores. But that's sort of the work that can be done fairly inexpensively now and fairly rapidly. So we're certainly going to try and leverage some of this. Obviously, as I mentioned yesterday, increasing access to organs is vitally important. Many of us feel that the lung allocation score doesn't take into account a lot of variables that we already know predict mortality for people with CF. And so we feel that the lung allocation score could potentially be improved to more accurately predict waitlist mortality. And the nice thing about this is that UNOS is willing to listen to us. They've invited us to the table. They want us to bring the data. They made it clear they're not going to find the data for us. But that's okay. That's what we do. And we've merged those data sets, as I mentioned yesterday. So we're hoping to make some progress there. We may learn that the lung allocation score is actually perfect and that we're wrong. But we may learn that we can be able to tweak it some. We've also identified ways when a physician feels that their patient is sicker than the lung allocation score would indicate, and feel that they need to be transplanted more rapidly, they can petition UNOS. But petitions often don't get very far. So we've brought together a group of people and we've developed a template that we hope will get ratified at our steering committee meeting next week for the sites within the consortium to use when they want to appeal a lung allocation score and maybe make that appeal more effective. And in fact, we've gotten some input from UNOS. So again, we are partnering with UNOS. And then, as I mentioned yesterday, our advocacy and policy folks have really joined forces with us to prepare a public comment, a statement in terms of this new geographic distribution. So just to make it clear, the way it has worked up until Thanksgiving of 2017 has been when an organ became available, the person within a donor service area, so within that organ procurement organization area, with the highest score would get first crack at those lungs. UNOS has now changed that to a 250-mile radius from the donor center that would get those lungs. So the sickest person within 250 miles, which means now that sicker people should get lungs before people who are less sick. And they're talking about potentially a 500-mile radius, and that's actually part of the debate is what's the right number. And I'm not sure if it's actually quite that simple. I think it may even be more nuanced because I think they need to think about population density because a 250-mile radius or a 500-mile radius means something very different in the Northeast than it does in the Northwest, for instance. So we're going to be commenting on this. And then I'll pass it back to Erin.
I'll just wrap it up with the support. So what are we doing to support people along the transplant journey? There are quite a few things. The first is CF Peer Connect, which we've heard about quite a bit over the last few days. The peer mentoring program. So there are patients who have gone through the transplant journey who are available as mentors. Community voice. This is provides opportunities for people with CF and their family members to have an active say. And I can tell you we've tapped into community voice a lot. All of our committees have people with CF on them as well as family members. And we really do take that very seriously and make sure that we listen to that voice and incorporate them into our work moving forward. The CF Mini-Con on Transplant is August 5th, and that one is also going to be available to family members, which I think, again, for this population is extremely important because you cannot get through this without your support system, and I think it's extremely important to have them involved from the very beginning. And then lastly, I'll just wrap it up with Compass. We have beefed Compass up, and they can help. They can help with the transplant support. They can help with insurance coverage questions and options, help find financial assistance throughout the transplant experience, connect you with resources for support for people with CF going through the process. Educational resources can point you in the right direction of where you can find transplant centers. There's actually a great website called srtr.org. It gives you all of the information you need to know, but it's daunting to go through that. So they are able to assist with that process, and then helping to identify some academic scholarship opportunities as well. So with that, I think we're finished, and we actually have 0 questions. They must have fired them all off last session because we barely finished. But I just wanted to thank you all for coming. It's a great privilege and opportunity to be here, and I'm literally my dream job, so thank you.
Well, that's good. That's great to hear.
I'm not going anywhere. I know I've had a few jobs in the past, but
so if anyone out in the audience has any question for us.
Sure. So the question is, what is the lung function, that magic number where we start talking about transplant? It's a great question. It came up last session too. So I'll start and then Al can probably finish this one up. But right now, the number that most people think about is 30%. We are trying very hard to push that up to 40%. And that does not mean that if your lung function is 40% or even 30%, that you need a transplant tomorrow. Some people may wait 1, 2, 3, 4 years, even longer once their lung function hits that mark. But our hope is that by talking about it earlier and normalizing the conversation, you're more prepared. You're in a better position once you get there, and you have everything you need to make an informed decision about, is this the right decision for you? Do you want to pursue transplant, or are there other options? So right now, it's 30% is the number you'll hear mostly, but we're really, again, trying to look more at 40% and below.
Yeah, and the important, I'll just add, the important aspect about that is, it's not lung function alone that tells you, oh, you need a lung transplant. There's several different variables that a clinician will look at, including the rate of decline in the lung function, including the number of pulmonary exacerbations you're having in a year, the number of hospitalizations. Are you coughing up large amounts of blood? Have you developed a collapsed lung? There are many other variables. I think our community became very focused on that magic number of 30% because of data from some 20 years ago that showed that when people with CF crossed that threshold, the median life expectancy, so 50% of people were still alive 2 years after crossing that threshold. And back then, to get a lung transplant, it was purely time you spent on the wait list. And since the wait list usually took 2 years, people, CF docs especially, took a hold of that number as a guide. But just very recently, actually, Kathy Ramos and her group in Seattle did a study of a current cohort of people with CF. And now when you cross that threshold of 30%, median survival is over 6 years. So not only has survival overall improved, survival for people who are really, really sick with advanced lung disease has also improved over the last couple of decades.
Josie? Oh, I'm sorry.
With your, I think it was the second slide that showed the graph with the decline as far as the survival rates. Has the foundation looked at any sort of partnering with any of the health or fitness organizations, NASM, ACSM, NSCA, as far as pre-transplant and post-transplant to potentially find a standard of protocol that would help slow that or be maybe better than the potentially just go and exercise?
Yeah, no, that's a great question. We have not had any formal partnership, but there is some transplant programs, for instance, that really focus on physical rehab, physical therapy, exercise programs. One of the sites we've already started the benchmarking process. I didn't mention that. We visited Duke. And they have a very, very strong program. And in fact, they are missionaries when it comes to this, and really attribute a lot of their success to exercise. So we're gaining information and learning, and this may be things we spread to other sites. The Toronto group, which Aaron has also visited, also has a very big focus on and, as you say, a formal program. Yeah.
Follow up on that before I ask my question. Do they have better outcomes, Duke and Toronto?
So Toronto has excellent outcomes, and Toronto does a lot of things that I'm hoping our programs will think about doing. There are realities in terms of they work under a different healthcare system than we do, but I do think that there's a potential for a lot. A lot of what they do is relationship oriented. The way their CF program and transplant program work together, and this vision of shared responsibility that we have for U.S. programs, they're already doing it there. So they do have excellent outcomes. Duke has excellent outcomes. Yes.
But my real question was the purple line. Why do our patients have a longer life than other transplant patients?
Yeah, we all have our hypotheses and postulate on this. I tend to think it's because people with CF who get a lung transplant tend to be younger, have, in a sense, fewer comorbidities in terms of having heart disease and atherosclerosis and other things like that, but also, very importantly, are used to a difficult regimen. Someone who develops pulmonary fibrosis, that's very acute. These are people who are well and all of a sudden are deathly ill. It's not a gradual decline for someone with pulmonary fibrosis. It can be very rapid. So they're not used to the frequent doctor visits, frequent procedures, and a litany of medications that they have to take. People with CF are used to all that. So I tend to think that helps and that contributes to that survival. But it's a theory.
And I'll just add to that real quick. At Hopkins, we had a really great relationship with our transplant team, and a lot of the post-transplant coordinators, they knew right away who the CF patients were. They always would joke about them being the easiest because they were, like Al said, so used to this very intense regimen. And, for them, there's a lot of things that they're able to take away after transplant. They add a lot of pills on for their immunosuppression, but compared to what they were already doing, it tends to be a fairly easy transition in that respect.
And another follow-up, and you probably have already thought about it, but have we been studying the fact of what people's lung capacities were with CF when they get their transplants to how long they're living? Because we're treating this like it's a lung disease, but it's still affecting all the other organs, even though now they have a healthy set of lungs put into them. So the question would be could they be moving up because of the other issues, not the lungs? And how are we going to balance that? Because now that you get the fresh lungs, now you're going to see the other problems occurring.
So, you mean other complications of CF? Like, yes. Absolutely, absolutely. But we're certainly seeing this as have been more successful in CF in and of itself, right? So recently we just released the colorectal cancer guidelines, right? Because the older our CF population gets, there are these other complications that do emerge. But in another way of looking at it, I would say obviously this is a good thing because it means people are living longer.
I think we probably have time for one more.
I have a question about comorbidities and especially the consortium you're putting together of the 10 hospitals. Do you see a day when hospitals will have standard protocol about different pathogens that they will and will not allow into their program, specifically Mycobacterium abscessus?
Yes, so we are actually, our steering committee is coming together next week for our second annual meeting. And one of the things that I'm going to be talking about there is just that, is figuring out, which centers are transplanting patients with certain, with Cepacia, with abscessus, with Acrobacter. That's another one we don't talk about much, but it's also one that a lot of centers are not going to touch. So ideally, we would like to, with their input, figure out and put together something that is available so that it's transparent and people know what different centers are willing to take on.
Yeah, but were you asking if we could get them all to agree on? Yeah. I don't think we'll get there in terms of what each particular program considers to be an absolute contraindication to transplant. What we can do, though, is work on doing research studies and gaining more information so that we're making very informed decisions when we decide one way or another. So a lot of it is really based on their own experience as well as their own interpretation of the medical literature as to how they want to proceed. Burkholderia Cepacia is sort of the classic where really virtually all programs in the United States will not transplant someone who is chronically infected with Cepacia. But Pittsburgh does. So why does Pittsburgh do that? And Dr. Paluski is very passionate about this. It's because when he looks at the data, what he sees is, yes, very poor results when you look at that Kaplan-Meier survival curve, but all of it is within the first year. So for people who are transplanted with Cepacia, you're looking at a 40 to 50% one-year survival. So 1 year. That's really pretty poor, and that's why most programs won't do it. But then, when you look at the extended survival, they actually do just as well as anybody else. So long-term outcomes for those who can survive that first year is just as good as anybody else. And so in his mind, since long-term outcomes are just as good, and now you're making decisions about transplanting someone who has many years of life ahead of them versus maybe someone with COPD who's already 75 years old. And yet transplant programs are routinely transplanting people like that. He thinks people with Cepacia deserve a chance to transplant. But that's sort of an ethical.
Yeah, so it just really depends on how different doctors.
Yeah, and I'm not sure you can regulate that. All you can do is provide data.
And I think to be completely transparent too, outcomes are a big deal for programs, and I think a lot of it deals with the risk they're willing to take on their outcomes.
And that's a good point. And that's something, though, eventually I would love to see us have this discussion with UNOS in terms of how do you grade programs and should you take points away from a program because they're aggressive and are pursuing something that maybe they're studying and trying to make better, right? So how do you find that balance? Because how do you ever get better at something if you're not trying?
Thank you all very much.
Thank you.